Well, these are
Yeah,
her,
absolutely.
so these are their side work, so she has to make sure she
Yeah.
does what she does. But
Guarantee you they got
oh,
one
yeah,
right.
fish came out of the form.
Pretty
What
much.
now did that?
These she has to write, these are her
We
new
have till December
Okay.
to do
So,
two.
her and her friend, taking them her friend after
Get that. Yes. All right. Is it working? Perfect.
Yeah, there you go.
Okay. Good afternoon. I was told it's time to start, and it's a pleasure to be back in Birmingham. This is my alma mater, UAV, a few years ago, and we're going to go over the course of the next hour through a few new developments in antiretroviral therapy. And this is meant to be an interactive session, so you will see that we'll have breaks during the presentation for people to give me their opinions or ask questions. I was asked to not move except for my lips, so I'll stay right here and I will not wander around. So I think we went, I don't know if we went through the housekeeping, how to get the voting. You have a paper on your table that has a QR code. If you point your phone on it, it will allow you to be able to participate in the voting. So that is good for us to have an idea of how the lecture went and whether the concepts that we were trying to cover were indeed well perceived by the audience. So I really encourage everyone to look into that QR code and participate in the voting. We'll have a few test questions to see if the voting works. For every item or every question that counts, we will have a pre-survey question. And then we will cover the relevant material, and then we'll have a post assessment. And now this is not tracked to a specific attendee, but it allows us to figure out if before and after we cover the material, the understanding of those materials were improved. So here's a test question. So if you choose one of the following cities to visit this year, which one would you select? Bangkok, Dubai, Johannesburg, Birmingham, no, it's not here. London, Paris, Sydney, or somewhere else. And there will be 10 seconds to vote, and then you will see the answers displayed here. All right. So it's usually, most people want to go to Paris, so do I. So let's look at the next question. What is your degree type? Physician, physician assistant, nurse practitioner, nurse, pharmacist, other healthcare professional, or non-healthcare professional? Please vote. Great, so I think we have a good mix of attendees, and we will make sure that the material that we cover is relevant to everyone. Next question. If you are in practice, how do you identify your specialty? As an HIV specialist, an infectious diseases specialist in general, family practice, general practice, or internal medicine, pharmacy, or other? All right, the other category is winning, so we'll find out who these others are. So this one, last question, is for bragging rights. So how many patients with HIV infection do you provide care for in a typical week? Anywhere from fewer than 10 to more than 100 patients in a typical week. All right, so there's also a large range of expertise and busy practices. So let's go right on. This is the first question. Your colleague is interested in implementing same-day antiretroviral therapy initiation at their institution. They ask about evidence from the so-called RAPID program at UCSF, University of California, San Francisco, where time to viral suppression was compared among 3 periods. The first period was 2006 to 2009, when CD4 guided antiretroviral therapy guidelines were followed, and that was followed by 2010-2013, when the universal antiretroviral therapy initiation guidelines were followed, and then finally 2013 to 2015, when the same-day antiretroviral therapy or rapid antiretroviral therapy intervention was initiated. So which of the following is true? How would you counsel your colleague about time to HIV RNA suppression with the so-called same-day or rapid ART initiation? A, there is a faster suppression versus the CD4 guided ART period only. B, there's a faster suppression versus universal ART guidelines period only, or C, there was a faster suppression versus both the universal ART guidelines period and the CD4 guided ART period. And then D, there was no difference in time to suppression between any of the periods aforementioned. Or E, you're unsure, you just want to be left alone. So let's see what the correct answer is. Now we will not discuss the answer until we cover the material, and then we will have that question on the board again. So the majority thinks that there was, with this rapid ART, a faster suppression compared to both the universal ART and the CD4 guided ART periods. So, next question. A colleague asked about evidence for the two-drug dolutegravir plus lamivudine, or GTG plus 3TC, as initial antiretroviral therapy. Now, based on the recently presented Gemini 3 studies, how would you counsel your colleague regarding the DTG plus 3TC as initial therapy? A, that therapy, the two-drug therapy, was inferior compared to the three-drug therapy and no resistance was observed, or that regimen was inferior and resistance was observed, or C, that regimen was non-inferior, which means it wasn't much worse than the three-drug regimen and resistance was observed, and finally D, that regimen was non-inferior and there was no resistance observed, or E, you're unsure. Let's look at the responses. All right. Among those who are not unsure, it was that the regimen was non-inferior and no resistance was observed, but the majority was unsure. Good. Let's continue. Next question. Based on evidence from phase 3 trials, where has long-acting injectable cabotegravir plus rilpivirine shown efficacy as an intramuscular injection after viral suppression on oral regimen, or as a subcutaneous injection, again after viral suppression on oral regimen, as an IM injection with or without prior suppression on oral therapy, or as a subcutaneous injection with or without prior suppression, or E, unsure. So this is a two-drug regimen, injectable, and the question is, in what context has it been found to be efficacious? All right, again, among those who are not unsure, it was the majority think that it was an IM injection in people with or without prior viral suppression on oral regimen. So this is the overview. We will base each of our of the segments of the talk on one of those questions that you just answered. So it will be a case-based discussion on rapid antiretroviral therapy, followed by evolving issues in combination therapy, and then evolving issues in switch. So combination therapy as an initial regimen or switching from another regimen. And then we'll finish with so-called on-demand pre-exposure prophylaxis, and I will explain when we get to that. And we'll leave some time for questions and answers. So rapid antiretroviral therapy first. What does that mean? This is a case of a 32-year-old asymptomatic man who was found to be positive on the 4th generation HIV testing and confirmatory so-called Genius HIV screening test. Now, he is immediately referred to your clinic for care. He has no more physical examination and is anxious to start treatment. You order the following from the laboratory: CBC, complete metabolic profile, hepatitis A, B, C serologies, CD4 count, plasma viral load, and HIV-resistant genotypes, as well as the HLA-B5701 genotype. For those who haven't been familiar with that test yet, should it be negative, it means that you could prescribe abacavir without fear of hypersensitivity reaction. So you order all this, and then you have a further discussion with the 32-year-old man, and he wants to start treatment right away. He's ready. So what is your advice to him? So this is based on studies, this one in the studies that have shown importance of rapid antiretroviral therapy. Now, for background, traditionally, when a person like him would show up in your clinic, you will wait for the results of all those tests that I just mentioned to come back. You will assess his or her readiness to have it, whether psychologically or otherwise, and then they will come back to your clinic a couple of weeks or later to finally start antiretroviral therapy. The new concept suggests that you want to start antiretroviral therapy within a week or two of that person presenting. Some of programs will start antiretroviral therapy before that person leaves clinic after their diagnosis. So systematic review of antiretroviral therapy initiation within 14 days of eligibility determination across 4 randomized clinical trials, and this is the result. Compared to the standard of care, which I just described, the same-day antiretroviral therapy increased the likelihood of antiretroviral therapy initiation, first of all, which goes without saying in the first 90 days, but also increased the likelihood that the patient will be retained in care, and finally that the patient will be viral load suppressed at 12 months. In fact, there was a hint at, I don't know if the pointer would work. No. I can see if I can point this way. There was actually a hint that you might have a lower risk of dying if they started the treatment in the context of a rapid initiation antiretroviral therapy. So this is a concept that slowly is gaining acceptance, and we will see what the data shows. So, and this is what the question alluded to. One of the centers that adopted this program is San Francisco, where rapid antiretroviral therapy was practiced, I believe, starting in 2013. So this is a same-day antiretroviral therapy initiation, which included access to HIV provider, lab, counseling, and in this particular setting, the loss to follow-up was similar in the rapid protocol versus non-rapid protocol. But compare to the period before rapid antiretroviral therapy initiation, that is 2010-2013, when different ART initiation strategies were in place, the rapid protocol led to a faster HIV RNA suppression. This is what is presented here. And finally, in the graph on the right, you will see that this is the proportion of people who attain viral load suppression, fewer than 200 copies per milliliter. And that proportion, of course, increases as you start. There is 0 person who is suppressed when you start, and after a period of time, you will see the proportion will actually achieve that suppression. Here, when the therapy was CD4 guided in green, that proportion was lower, and people achieved the viral suppression much slower than when antiretroviral therapy guidelines were recommending universally to start antiretroviral therapy without waiting for the CD4 count to decline. Then finally, in blue, the rapid strat, which has the fastest rate to viral load suppression, faster than the 2 other previous periods, whether it's CD4 guided or universal antiretroviral therapy, but that not in rapid fashion. So this is the data from San Francisco. And then another, this is what they call the Ward 86, is the San Francisco clinic that did that study. So the time to virologic suppression, so retrospective analysis of 216 out of 225 patients, or 96%, refer to the RAPID program between 2013 2017 showed that 95.8% have achieved a viral load of fewer than 200 copies. By the way, again, as an editorial, even if undetectable viral load is what the norm is or the target or the goal is, it's agreed that when your viral load is fewer than 200 copies or you have occasional viremias that say below 200 copies, you are not likely to progress faster than people who have undetectable viral load. That's what that threshold, you keep seeing it popping up, the 200 copies per ml, because people who stay below it don't have a faster rate of progression or complications. So it's accepted as a target. So, and even if you look at those who are the last recorded viral load of fewer than 200 copies, there was a pretty significant proportion, 91.2%. So this is the RAPID program in San Francisco. Now, how did the guidelines bodies react to this data? Variably, as you might say. For full disclosure, I'm a member of the DHHS guidelines, but my views do not reflect the DHHS guidelines. I'm just presenting what the guidelines bodies have recommended. The DHHS says this is a strategy that is still investigational, and it is resource intensive. You need to have ability to have all the wraparound services around that patient to be able to start it, including counseling and pharmacy, and ability to provide the drugs in general. And the long-term benefits are not yet proven in the United States. So that is the view of the DHHS at the latest recommendation. WHO and ISUSA have a conditional acceptance of this strategy. WHO says it's recommended when feasible, while the ISUSA says to start antiretroviral therapy as soon as possible, including immediately after diagnosis, which is the rapid start concept. So when you start, before you have the benefit of either the viral load or the genotype or other testing like hepatitis B, it behooves you to pick a drug that a regimen that is likely to work, regardless of whether the person has resistance that was transmitted or not, and B is likely to be safe. So this limits you, according to these recommendations, to dolutegravir plus FTC or 3TC plus TAF or TDF, or bictegravir FTC TAF, darunavir ritonavir FTC or 3TC TAF or TDF. Now, it's not recommended to start somebody on a regimen containing non-nucleoside reverse transcriptase inhibitors if you don't have resistance testing, because if somebody is to have transmitted drug resistance, it's by far more likely that it will be against these drugs, or the so-called K103N, one of the most common in transmitted drug resistance. And it's better not to prescribe a bacavir in the context of rapid start, because if you don't have the HLA-B701, like I said earlier, you might not know if that person is likely to develop hypersensitivity to that drug. Another aside is that it would be better to have a drug regimen that would potentially cover hepatitis B if that person was to be co-infected. But that's a lesser recommendation, and these regimens will fulfill that obligation, that recommendation as well. So now let's go back to these outcomes. The same case when your colleague is interested in implementing that same-day antiretroviral therapy in their own institution, and they want to lean on the experience of San Francisco Rapid Start program. Now, what would you tell them? Would you tell them that there is a faster suppression versus CD4 guided therapy versus universal antiretroviral therapy versus both, or there was no difference? Please vote again. The first vote was the primary. This is the final vote. Okay, let's see. Perfect. So I think this is what the result was supposed to be is that this rapid start was found to be leading to a faster rate of suppression versus any of the other strategies before it. And this is what the curves on the right show. So now let's look at what is your experience. Is anyone doing rapid antiretroviral therapy in the clinic program? No. I realize that it's a concept of both coasts. They do it in San Francisco. They've also done it in Washington. And a few of us between the two coasts have practiced that. Now, would you recommend that? Would that be feasible? Would you recommend that for the particular patient that we just mentioned? This was a 32-year-old, just diagnosed, has no significant comorbidities. He just got all the labs, but you don't have anything back, but physical examination is normal. Is that somebody that you think rapid antiretroviral therapy would be advisable for? Anybody has an opinion on that? No? Okay. So, and is there a general acceptance of the regimens that are recommended for rapid ART? Just recapitulating that, the reasons for that you don't want to use anything that is likely to, that the person is likely to be, the person's virus is likely to be resistant to. So staying away from NNRTI is the norm, avoiding a back if you don't have hypersensitivity. So that's basically it. So I'm not sure if it's not practiced in most places because of the unavailability of the resources. Like I said, the DHHS guidelines said this is a resource-intensive intervention. Anybody has any concerns about not having enough resources, or what other pitfalls do you see that program having? Any opinion? Anybody wants to say why they would not use this? Would you? No. Okay. So let's move on to the next concept. And this is evolving issues in first-line combination therapy. And so, again, it's important to find out if what people think about this. Now, for the past 20 years, actually 20 plus years now, closer to 25, we had hit a sweet spot in HIV antiretroviral therapy. And that sweet spot was 3 drugs. Arrived at it because we started with just 1 drug in '87, then added 2 drugs, and now 3 drugs are the norm, have been the norm for over 2 decades. Now, we boldly going backwards to a couple of drugs, only 2 drugs. And that is one of the emerging strategies. Now, coming soon to a pharmacy near you is a 2-drug antiretroviral regimen. And so the data that we're going to present is what the efficacy and safety of these 2-drug regimens would be. Now, another concept that you may want to consider is the generics. A number of drugs that have been used and are still in the preferred list of antiretroviral drugs are now going generic, and combinations between them and those that are still commercial, non-generic might be considered. Cost considerations have to be factored in to the decision making, and as well as toxicities, especially population is getting older in general. So here's a 31-year-old asymptomatic woman who presents to your clinic after recently being diagnosed with HIV. Her physical examination is unremarkable, and she has no comorbid conditions. Laboratory information, normal CBC and normal renal function. Hepatitis A, B, and C are all negative. HIV viremia is 110,000 copies per milliliters, and CD4 count is 310. Now, wild-type HIV was detected, meaning that she does not carry a virus that has any resistance associated mutations, and she's interested in your thoughts regarding a simpler regimen that she had heard about, and some of which are probably less expensive and have even allowed her to get financial incentives. Now, so what is there that is simpler that she might avail herself of? So here are the initial studies that made a foray into a two-drug regimen. Now, I believe ever since AZT and Indinavir in the early, the late 80s, early 90s, there hasn't been two-drug regimens. Now, this particular study in Argentina combined lopinavir ritonavir with lamivudine 3TC alone and compared it to a more traditional three-drug regimen, lopinavir ritonavir, with either 3TC or FTC and another nucleoside reverse translation inhibitor. Now, the long story short is that this study was one of the first to show that the virologic efficacy of that two-drug regimen was comparable to that of a three-drug regimen. And that was followed by another study that used another protease inhibitor. This time is darunavir ritonavir, but the concept is very similar. Adding lamivudine or 3TC to darunavir ritonavir, they compared it as this two-drug regimen, not counting the ritonavir that is boosting the darunavir, of course, to a triple regimen of darunavir ritonavir plus 3TC and TDF. Again, the results was the same in that that two-drug regimen was non-inferior to the three-drug regimen. Now, bigger studies, because there were two of them, Gemini 1 and 2, each one of them having, I believe, 700 plus patients, took that concept further into comparing an integrase inhibitor, dolutegravir, with a 3TC compared to a triple regimen of dolutegravir plus FTC and TDF. So this is the dual regimen of dolutegravir plus 3TC compared to dolutegravir, FTC, and TDF. And as you can see by the fact that the blue and the red curves are practically superimposed over the course of 96 weeks, these two regimens were equivalent. And so the two-drug regimen was non-inferior to the triple regimen. And this is a very large study for a 2-year follow-up. And if you break down the people who were enrolled in that study by CD4, either less than 200 to more than 200, or viral load less than 100,000 to more than 100,000, you will see that the two regimens were equivalent at all these strata, except maybe the low CD4 count where dolutegravir TTC seems to have underperformed. So, but when they reanalyzed the data with this particular analysis, which means treatment-related discontinuation equal failure, TDRF, they found that the two regimens were equivalent across CD4 and viral load strata. So again, when you see, as I did that the first time in the rapid art, now I'm doing that with the two-drug regimen, whenever I present newer data, I present how the guidelines bodies react to the data, because the guidelines bodies look at the data and decide how to change their recommendations. So in the DHHS and ISUSA recommendations on the use of two-drug regimens as first line, as follows, that these regimens should only be used in patients who cannot tolerate abacavir, TAF, or TDF. So these are the now recommendations. So for example, you have somebody who has this mutation, HLA-B701 positive, that predict hypersensitivity to abacavir. At the same time, has a high risk of cardiovascular disease, so abacavir may not be the best thing, and a very, very poor kidney function, where TDF and TAF may or may not work for them. Now you have to then go outside the beaten path and find a good regimen. This is why these regimens are recommended. Now, two drug options are presented to you data with lopinavir, ritonavir plus TTC, as well as darunavir, ritonavir, TTC. There is another one, darunavir, ritonavir plus raltegravir, which worked equally well except for people with very low CD4 and a high viral load. And then I finally presented to you dolutegravir plus 3TC. So there are growing options for two drug regimens. We're finally breaking down the paradigm from the triple regimen to possible two drug regimens. So here's what this question to ask it again. So in the interest of time, I'm going to fly through that question. Do you think that two drug regimen is either inferior or non-inferior with or without resistance? So that's answers A, B, C, and D. Or E, you are unsure. So again, answer A and B whether it's inferior, answer C and D is whether it's non-inferior, and then with or without resistance. Please vote. Let's see, okay. All right, perfect. I think this is it's non-inferior and there was no resistance. Case closed, right? So this is what the Gemini 1 and 2 over 96 weeks showed just that. So now, how do regimens, including generic drugs, fit into the therapeutic landscape? So some drugs are going generic. 3TC is one of them. TDF is another one. So even if in the commercial names or brand names, TDF and 3TC were not paired together, they could in generic formulation. So these are the, similarly, there is a new formulation of efavirenz, but not at 600 milligrams, but at 400 milligrams with TDF and 3TC. Usually in the commercial name, TDF was paired with FTC, but 3TC and FTC are really similar. So now these are things for people to reflect upon, depending on what's the what's the pay mix that the patient population have, and what are the potential advantages of considering these generic formulations. So, and the last option we mentioned was a 400 milligram efavirenz, and the traditional dosing being 600 milligrams, and again paired with TDF and FTC was found to be non-inferior to the 600 milligram efavirenz plus TDF and FTC. And even more intriguing is that the CD4 count increase seemed to be better with the 400 milligrams than the 600 milligrams. And the 400 milligrams was associated with slightly lower frequency of adverse drug events, including neuropsych side effects. So it appears to be safe and efficacious to use a lower dose of efavirenz and get away with it. So what's new? We have a new kid on the block. This is a block that hadn't had a new kid in a long time, which means the non-nucleoside reverse translation inhibitors. From dilaverdine to nevirapine, then efavirenz, we had it in rilpivirine and etravirine, but now we're having doravirine, which is the newest of the non-nucleoside reverse translation. My battery is running low. That could be said of myself. So is it going to carry us through the end? I hope. Okay, good. So, and so that is for treatment naive. And again, doravirine has been combined with 3TC and TDF, and two components that are going generic. and as a complete single tablet regimen. So same thing for any combination that contains TDF, cautious for bone toxicity as well as kidney toxicity. That's the bottom line. And you see here in these studies, drive forward, compared doravirine to boosted darunavir, and Dravired compared doravirine to efavirenz. So it was non-inferior to either boosted darunavir or efavirenz. So something to consider. So this is the era of dual therapy might be upon us, maybe coming soon to a pharmacy near you or a clinic near you. You have to consider that. And then are you considering generic options? So anyone wants to offer the experience to people now, whether that fits in the treatment landscape. And then another thing to reflect on is if you would use that lower dose of efavirenz, as the study that we just presented suggests it's safe and efficacious. So now evolving therapies in switching. Now I'm going to try to finish quickly because I don't want to run over time. So this is a 56-year-old man who presented with pneumocystis pneumonia approximately 10 years ago when he was diagnosed with HIV. But now he's on treatment, darunavir, ritonavir, TDF, FTC, viral is undetectable. CD4 is between 300 and 450, so not too shabby. And current medications, in addition to antiretroviral drugs, are metformin for hypertension, benazepril, metformin for diabetes, and benazepril for hypertension. And during the past 3 years, he has experienced progressive decline in renal function from a clearance of 80 to a clearance of 45 with stable proteinuria. So that's of concern. So dolutegravir rilpivirine it has been approved in 2017 for people who are viral suppressed and no history of failure, but for whom you may want to consider switching the regimen, probably because of adverse events and other things. So that's dolutegravir rilpivirine. Now, there were other dual therapy regimens for consideration. Now, remember, first we discussed the ND study, darunavir plus 3TC, as well as the Gardel study, lopinavir plus 3TC, in naive patients, those who are non treatment here. Now we're considering studies for 2 drugs in people who had already experienced another regimen, either with suppression or not. So lopinavir, ritonavir plus 3TC again, atazanavir, ritonavir plus 3TC, all have been shown in randomized controlled trials to work in somebody who has already achieved suppression, but that you want to change. So these are strategies to consider: dolutegravir plus 3TC, darunavir plus 3TC, and long-acting injectable regimens, either monthly or other monthly. Now, not approved yet, but probably will be soon, before the end of the year. And so these are 2 studies I'm going to go through quickly. People were on tenofovir and lefenamide-based triple regimen were switched to dolutegravir plus 3TC, and they did just as well. So we first talked about dolutegravir plus 3TC in terms of naive, but these are experienced patients who given that regimen and work just fine. And the dual Gesida, similarly, people were switched to darunavir, ritonavir plus 3TC versus continuing a triple regimen, and they did just fine. Again, compare and contrast to the ND study where they started on darunavir, ritonavir plus 3TC. So ATLAS and FLAIR are 2 studies that take us to a completely new paradigm, that of the injectables. And these are intramuscular injections of antiretroviral drugs. In this particular concept, these were monthly injections. The only difference between these 2 studies is that for ATLAS, these people were already virologically suppressed on another regimen, and then they switched to these monthly injections and did well. While in FLAIR, they started first with dolutegravir as a TTC just for 20 weeks, got undetectable, and then switched to the injectable. The main thing to remember is that none of these injectable arms immediately started with injections. The people took as a so-called oral lead-in, cabotegravir rilpivirine orally, and then only after week 20, 4 weeks, did they switch to injectables. The reason is that it wasn't clear still whether you can immediately start injecting something that stays in your body for weeks and months. What if there was a reaction? You can't take it out. So they wanted to first see how somebody would do with the oral regimen that have much shorter half-life. And if things don't go well, you can always stop. So that's why these studies are designed like that. But in terms of efficacy, these intramuscular monthly injections work just as well as the oral regimens, whether in a suppressed or naive person. Now, there were some resistance that all seemed to be from Russia. So this is a Russian conspiracy, Russian collusion. And it's unclear why that happened. There's intense research in that particular subtype of HIV where they got the resistances. But by and large, this was a very efficacious strategy. So efficacious that they are considering other studies in the same vein. But for the Atlas 2M, they're moving people to injections every other month, not just every month. I personally think this is a much more workable strategy. If you're going to have people come to clinic for injections and never take pills again, bringing them every other month is a lot more practical than every month. So then the other one is the Latitude, which is a very different concept. Here they're trying to see if people who struggled with adhering to pills will be better with injections. So it's purposely recruiting people who had adherence issues. And so back to this question, now, is it the case that the injectables were intramuscular or subcutaneous, i.e. A and B, or is it the case that they were given after viral suppression or with or without viral suppression? So A is IM after viral suppression on oral lead-in, and B is subcutaneous after suppression oral lead-in, and C and D as with or without oral therapy prior. So please vote. All right, this is good. So for those in the third group, so this is IM true, but it was after an oral lead-in, oral therapy. So this is what the answer was, which is correct. And this slide, I'm not going to dwell on it too much, but simply say that acceptability and preference is actually quite high. It's higher than personally I did expect, acceptability of the injections. And so this is just what this slide means. So as the hour is advanced, since we already had some of these discussions about the switch, I'm going to finish with the so-called on-demand PrEP. Now, pre-exposure prophylaxis, as it is practiced today, as it is recommended by the CDC, is that everybody takes one pill once a day to prevent HIV infection. So that's a practice of PrEP. The on-demand PrEP means you take PrEP when you need to, i.e. when you're about to have sex. So you're about to have sex. If you can't remember in those circumstances, you take 2 pills, and then 24 hours later you take 1, and then again 24 hours later you take another one. They call it the 2-1-1. That's the on-demand PrEP, a largely French idea that has permeated on these shores. So this is a 47-year-old man who has sex with men who presents to an STI clinic with a rash on his body, including palms and soles and his feet. So evidently he has syphilis. RPR comes back positive. He tests for HIV. HIV is negative, which is a good thing. and he has had syphilis in the past and been treated for GC, and it's taking drugs for both hypertension and diabetes. So labs show that he has a creatinine clearance of 50, rather borderline, and it states he has unprotected sex with different men and variable frequency, and has heard about this pre-exposure prophylaxis deal and wants to give it a shot. So this is the so-called hyper-gay study in France that laid the groundwork for this on-demand PrEP. Like I said earlier, the concept is 2 doses of TDF-FTC before sex, and then 1 dose 24 hours later and 1 dose 48 hours later. Now, did it work? Yes, it did, by and large, with a caveat that a lot of people ended up taking a lot of pills. So 15 to 18 pills per month means more than every other day. So it's is it likely that they took so many pills and they were almost on a daily PrEP, like as if they were on a daily PrEP? So the first analysis, a randomized placebo-controlled trial, means that this group managed to hear this, did very well. They have very good protection with this strategy, but then they wanted to do a sub-analysis of those who did not take as many pills, and they broke it down to those who had less frequent sex, who ended up taking an average of 9.5 pills per month. And in this group of less frequent sex, the efficacy was also great. So this on-demand strategy therefore was shown to work in this context. And another study again in France, ANRS Preveni, used the same concept of on-demand PrEP. Now, instead of compared to placebo, it was compared to daily PrEP. And again, so the primary endpoint was reduction of HIV therapy. Now, in the on-demand, there was not much higher rate of circumvention, which is very low than in the daily PrEP. Let me see if I can. So this is daily PrEP, 0 HIV incidence, on-demand PrEP 0.2, and in the global HIV incidence was 0.09 per 100 patient years. So, so PrEP had stopped 7 to 10 weeks before infection in both of the people who got infected. So even though in the arm where people got infected, they were infected because they had already stopped PrEP. So this on-demand PrEP was found to be efficacious in this particular setting. And since this was a high-risk population, it was estimated that the number of infections averted amounted to 143 in this population. So a concept that supposed to work. So daily PrEP users had more sexual partners and more frequent condomless sex, so a higher incidence of bacterial STI. What does that mean? Those who elected to take PrEP daily assume that their risk was higher, and so they self-sorted into high risk. So this is a less bright note on PrEP, which means that the efficacy in these 3 studies represented by the red bars, which were female studies, efficacy was not good compared to efficacy in all the other ones that either include men and women or exclusively men, where they have a high efficacy. Maybe it was because those female studies adherence tended to be very low, and if you broke down the studies into those that had less than a quarter of adherence to more than 3/4 of adherence, you see that those who have more adherence did better. So that is a possible behavioral explanation for why the female studies did not do well. There is also a possible biological explanation. The drugs that are used for PrEP achieve a higher concentration in the rectal fluid or the seminal fluid than in the vaginal fluid. So it's possible that women, the threshold for having a good protection is much higher. So maybe they needed to be a lot more adherence than men to achieve the same efficacy, because drugs may not be reaching the relevant areas at the as high concentration as in men. So that is a possibility. So again, finally, how do the guidelines bodies react to this data? The CDC says that this on-demand PrEP is not recommended. Just use PrEP every day. While the European Union says it's optional to use this on-demand PrEP, and the ISUSA also says that it is optional. So this is, again, in the PrEP thing, so we had TDF-FTC is what the CDC recommend for PrEP. Now, TDF, there's a newer formulation of tenofovir, which is tenofovir alafenamide, or TAF. Now, a huge study of 3,000 patients has just been completed, 3,000 patients per arm in the TDF arm and 3,000 in the TAF arm. It's just been completed comparing the efficacy of PrEP with TAF-FTC to PrEP with TDF-FTC, and they has similar efficacy. But the TDF-FTC had better, the TAF-FTC had a better tolerability for the kidneys and for the bones. So as you've seen in the treatment trials, using TDF led to lower bone density and worse kidney function than using TAF, the newer formulation. And the same thing applies here to the PrEP, so people who are uninfected. So what I think we went through over the course of the past hour are some emerging concepts. The first one being the rapid. So even if it's not universally endorsed yet, it's a concept that seems to lead to faster viral load suppression and possible better clinical outcomes in the long run. The second concept being, I would call it less is more. So you could get away with just 2 drugs like dolutegravir and 3-TC or darunavir and 3-TC and have as good virologic efficacy in a naive patient as in the triple therapy. The same thing has been seen in people who are experienced who switch to a 2-drug regimen. More importantly is the concept of injectable drugs, that cabotegravir and ripivirine being the first foray that the monthly injection has been proven itself, and that they may not be trying it now in a 2 monthly, every other month injections. And then finally this on-demand PrEP, that it's possible that you can get away with using 2 pills before sexual encounter and 1 pill 24 hours later and 1 other pill 48 hours later. Now, there's also a possibility, I did not get into that even in the daily PrEP, those who ended up taking 4+ pills per week, not every single day, but at least 4 times a week, had almost as good a protection as those who took every day. So I think that's it, and I'll stop here and let's see if anyone has any questions in the next 4 minutes. Let's see. Okay. Well, thank you very much.